the picture that is displayed in front of you, it's called as ECG. ECG or electrocardiograph. Okay, so that's an electrical instrument which helps us to depict or do some graphical analysis of the cardiac functioning. Okay, so it's nothing but a modified galvanometer. Okay, that means it has a sensor or a dial which has a negative terminal and a positive terminal, which is connected to your body. Okay, and with the help of that, the alignment of all the rhythms are depicted in a graph. Okay, now this machine, it uses, sorry, to determine or to do the electrocardiograph, we need a machine called as electrocardiogram. Okay, and the procedure that we use is called as electrocardiography. Okay, so whenever we talk about graphy, that means the procedure that we are using to determine the electrical rhythms or the potential fluctuations during cardiac cycle. Okay, so we record those potential fluctuations in the form of electrical activity of the heart, and the graphical depiction is called as electrocardiograph. Okay, the machine that we use is called as electrocardiogram. Okay, so before moving forward, we have to give in due some respect, or should know something about this person whose name is William Einthoven. Okay, so he's also called as the father of ECG, who in fact got Nobel Prize in the year 1924 for his contribution to the discovery of ECG. Okay, he is actually a Dutch, he was a Dutch physiologist. Okay, who taught in University of Leiden. Okay, so his major contribution, apart from discovering the ECG, as well as he also is given credit to discover or invent the triaxial bipolar system for recording the ECG and calculating side by side the ECG recordings. He also is given due credit to conceptualize the concept behind the equilateral triangle, or we tell those triangles to be Einthoven's triangle. We know now is the Einthoven triangle. So he was the person who conceptualized that. Along with that, he is also given the credit of inventing this Einthoven's leads, that is in lead 1, 2 and 3, and also he is also given credit for calculating the electrical axis or the cardiac axis. Okay, that we going to learn about all those things in the side by side topic. So we have nowadays 3 different variants of ECG that is available. Usually this picture that is showing here in front of you is called as your exercise ECG. Okay, in which we give stressful activities, or we record the ECG while doing some activities. We instruct the subject to do some exercises or some treadmill exercise. In this case, you can see there is a treadmill. We give that person this task of running around the treadmill or walking around the treadmill for certain distance. Then we keep on continuously monitoring the ECG rhythm, and we record that. This is an ambulatory or halters ECG. Okay, so this is ambulatory ECG device for continuous cardiac monitoring certain patients which need cardiac continuous monitoring if every second of their life. So example, the stent, people having any stent or any pacemaker, so they might need those continuous monitoring. And this is the body mapping ECG. Okay, MAPPING mapping. So it's a non-invasive identification of arrhythmic. So arrhythmic sources, like here you can see different variant colors are there. Okay, so these all colors variations are used for detecting any dynamic abnormalities in the cardiac functioning. So why as such ECG is so important? Okay, why we need to take this ECG recordings? Because we have some clinical examinations also present. Okay, clinical examinations of your cardiovascular system as a whole. We do physical examination, but why is there a need to we need to take ECG strip? Okay, so first of all, the reason is we have to also know about the position of heart. Okay, so it also tells you about the position with respect to the horizontal axis, the oblique axis, or the vertical axis. Okay, we also will be able to know the relative size of the heart, whether the heart has pathologically increased in diameter, or the cardiac chambers or the cardiac muscles are abnormally enlarged or not, or whether there is any abnormal atrophic areas or not. Okay, so all these things we can note down. Along with that, we also can calculate the heart rate, rhythm, and conduction of cardiac impulses. Okay, we will be able to judge all those informations with the help of the ECG strip. Then also obviously we can be able to know about the cardiac block. Okay, if there is a right bundle branch block or left bundle branch block, okay, like this, we will be able to also know whether there is any new rhythms been originating. Okay, any new rhythms which are sometimes called as extra systole and arrhythmias. Okay, and also we will be able to know the ischemic damage to the heart. Okay, the exact site, duration, and extent, everything can be detected with the help of an ECG strip. So whenever you see a person doing his ECG, okay, persons or subjects or patients ECG is being recorded, you see the person, first of all, they are lie down in a prone position. Okay, and sorry, supine position, and you see the person tight. Okay, this is not a typical positioning of the electrodes. Okay, you see some wires are coming from the machine. Okay, and it is going and being placed with the help of some materials. Okay, some glue like material which is attached with this end of this wire. Okay, the wires are something different looking, and we place it on the chest. Okay, so this is a schematic diagram how a patient is, we are recording the electrocardiogram. Okay, so this cups or these electrodes are this actually. Okay, so these are the limb electrodes. These are the limb electrodes which is attached on the limbs. Okay, so if this is a person having, we have 4 electrodes. Okay, so it has some designation. Okay, so red color usually is attached with the right arm or upper arm. uh, Left one is for your left arm. This one is used for your left leg. Okay, and this one is used for your right leg for the neutral. Okay, so we have the electrodes which are standard limb electrodes, okay, which is attached to the limbs. Okay, now we attached all the electrodes, and being the red black color is needed for the neutrality of the circuit. Okay, because it's an electric machine, so we might get some interference. So negate those interference, we use this neutral electrode. Okay, we attach it on the right leg. Now this cup shaped electrode that you can see, these are the chest electrodes. Okay, these are called as a chest electrodes. Okay, so from V1 to V6 we have 6 different variants of chest electrodes. So in short, we can say there are 2 different varieties of leads. The one is the standard limb leads. Okay, another is chest leads. Okay, so we have standard leads as lead 1, lead 2 and lead 3. Okay, apart from that we have another variant of the lead which is formed using these electrodes are, sorry, only the limb electrodes are the augmented. Those are AVR, AVL and AVL. Okay, that A signifies the word augmented, the VR, VL and VL signifies the respective names of the limbs. This is the right potential of the right arm, this is augmented potential of the left arm, this is augmented potential of the left leg. Okay, so like this we get 2 different varieties of leads while doing the electrocardiography, or the categorization may be based upon whether it's a bipolar lead or it's a unipolar lead. Okay, so bipolar means it has 2 poles. Okay, one negative and one other positive, and unipolar it has one point only, or one point, or one connecting point for this lead. Okay, so lead 1, lead 2, lead 3 and all the augmenteds are categorized under the bipolar leads, whereas V1 to V6 it falls under the unipolar chest leads. Okay, so another important point to note down over here is that what is AV. Okay, in this case I have told you what is augmented, so this means the potential of, supposedly I'm talking about AVR, so it will be augmented, or the word augmented means increased. Okay, so its potential will be 3/2 times of the VR. So there's a mathematical equation and derivation of this formula, so it's also mathematically provable how this potential gets amplified, because Einthoven, when he first invented the method of detecting the or recording the ECG, the potential that he was recording was very minimal. Okay, for doing calculation and extensive research on that strip is not sufficient enough. So for doing some calculation we need the amplification of the voltages. So we then later on, William was the person who developed some mechanics and some different manipulation in the instrument, and he came to instrument which gave the potential with a 3 by 2 times amplification with the potential. Now let's learn about the placement of the chest leads. Okay, chest leads, or in this case it's a unipolar lead, so we can also call those leads as the chest electrodes. Okay, so now what happens in this cup shaped, you might have seen the patient who are undergoing that ECG examination. You might have seen the physician or the technician places the cup shaped instrument, that is this, they are placing over the chest. Okay, now what are the areas? Now we are going to learn about that. Okay, V1. Okay, they are usually strategically placing in some areas around the ribs. Okay, so this is the diagram depiction of the relative position of the ribs. Okay, showing the relative position of the heart, okay, in the body in an anatomical position. So these lightly shaded area, these are the curve shaped areas, are called as the ribs. Okay, now take for example this area, this V1. Okay, this black square area, it is showing you the area where the V1. Okay, so there are 6 different chest leads or electrodes are there. We place in individual points like V1. V1 is nothing but we count the number of ribs and we place this suction balloon pump, suction balloon chest leads. Okay, so it has a suction effect, so there is an it's a balloon, so we just first of all squeeze the balloon and we create the negative pressure inside, and we then, just like the vacuum cup, we place it over the chest. Okay, so V1 chest electrode is placed at the 4th intercostal space, just right to the sternum. Okay, V2 is the same, only the 4th intercostal space just left to the sternum. Okay, so V1 is supposedly the anatomy portion. This is the right part of the body, this is the left part of the body, so V1 is placed relatively on the right side of the sternum. So supposedly this is the sternum. Okay, this is the right side, and V2 is placed just left. Okay, so just left to the sternum. Where V3 is placed, it is placed in between V2 and V4. Just let's know about the area of the V4 electrode placement. This is 5th intercostal space at the mid clavicular line. Okay, so if this is the clavicle, this is the clavicle, and this is the mid clavicular line, so we place at the 5th intercostal space at the mid clavicular line, and we just measure, okay, roughly the length between V1 and V2 electrode, and we place the V3 just over the V3 area. Okay, so this was the V4. Now V5 and V6. Okay, now V5 is placed on the same intercostal space, 5th intercostal space. Now this time we are placing this electrode at the anterior axillary line. Okay, if supposedly this is the axilla, okay, this hole is the axilla, this is the anterior axillary fold. That means we just trace down the pectoralis major, and just when the 5th intercostal space is touching the anterior axillary fold, we place it over there. V6 in the same intercostal space but in the mid axillary line. Okay, so there could be an imaginary mid axillary line. You can imagine that line and you place it over there. So there's another thing you should know in ECG is that there's another device which is attached in the ECG machine, that is called as Wilson's central terminal. Okay, so this is a modification to the Einthoven's ECG machine. Okay, so the year 1908, a fellow physician named F. N. Wilson, okay, sorry, in the year 1908 to 1931, actually the research was conducted, and the year 1931 Wilson devised this in modification to the Einthoven's ECG machine. Okay, so what it did, in a regular ECG machine, what happens, a regular ECG machine, there was an electrode, is a galvanometer, okay, having a positive terminal and a negative terminal, and we know there is three different electrodes: standard limb electrodes, then augmented electrodes, and standard limb electrodes and the chest electrodes. Okay, so now when Einthoven invented, I told you there was a flaw, there was a kind of a error that was developed because of the low amplitude of or potential that is detected with the help of the Einthoven's device. Okay, so what Wilson did, he connected all the chest electrodes, all the limb electrodes. Okay, if supposing this is the lead one, right arm, left arm, then left leg, okay, right foot, left foot. So he connected all these terminals via a central device having 5000 ohm of resistance, and it passed to the machine again. Okay, so what happens is that with the implementation of this modification, the person who is using this ECG machine, if supposedly there is the right arm, left arm, and the left foot ECG machines are connected to a central terminal. Okay, so supposedly this is the 5000 ohm. What happens if supposedly we have to detect the augmented potential of the right arm? Okay, so what happens, the right arm is connected to the one end of the galvanometer to the negative terminal, and the left arm and the left foot terminals are passing to this higher resistance. Okay, so what happens, because of the passage of this wire, so the 5000 ohm resistance, what happens, it is then connected to the positive terminal of the galvanometer of the ECG machine. Now because of the presence of this high resistance, what happens, practically this potential becomes zero. Now whatever potential you are detecting with this negative and the positive terminal, it will be solely contributed to the right arm, and that was found to be 3 by 2 times of whatever potential that was detected by the Einthoven's prototype machine. Okay, that's why this augmented machine was invented by Wilson, and it helped us to get those augmented values of right arm, left arm, okay, and left foot. Okay, so like this, supposedly we have to detect the left arm's augmented value, we will pass this solely to the to the negative terminal and pass the rest to wires through the resistance. Okay, then we pass it again. So like this we do the modifications of the Wilson's terminal. And what is the importance of the Wilson's terminal? Now let's come back to the ECG strip. Okay, so ECG recording, this is a typical ECG recording that we get. Okay, so we can see this is a kind of a graphical paper having some thick lines, okay, and some thin lines over there. Okay, there is an area where we record the patients or the subjects on which we are recording the ECG. His details are there, the patient's ID is given, the patient's name will be given, the gender of the patient, the age of the patient, and if supposedly some any additional requirement information is written on the below. Okay, then on the below we can see this is the area on which we can see the parameters of the frequency of the movement of the machine. Okay, the speed of the machine is given, the volt is mentioned. Okay, and some other information regarding the machine that we use, and sometimes also the name of the place from which we are doing this examination. Okay, and on the top right corner you can see the details. Now these details as such in this patient that we are getting, what the automatically the machine detects or determines the heart rate depending, analyzing all the graphs that is being getting. uh, you don't even have to do something anything. If you are totally relying on the machine, then the machine in fact gives you all the values that is needed for your diagnosis. Okay, and in fact this nowadays the machine even gives you the diagnosis, but the catch comes over here is that, take for example here, there is a low T wave. Okay, so whether there is an abnormality really on the ventricular part or the lower chambers of the heart in the patient, no, that was not the case. The patient was absolutely fine, but because of some abnormalities in recording. Okay, so it has to be done in a perfectly ideal condition. There should not be some any metallic instruments or gadgets or metals attached to the patient, as well as it should be not interfering with any other electrical gadgets around the vicinity. Okay, it should be perfectly done on the ideal condition, but that's not possible. So that's why there was some error somewhere in the procedure. So that's why the machine analyzed it to be the, although it's a sinus rhythm, it showed us the low T wave. Okay, so that's why a human involvement should be there along with your AI. Okay, so don't always rely on machines for your diagnosis. So you being a physician, you should be knowing what are the different parts of the ECG, what are the different graphs that we are recording, and how to determine all the individual parameters. Okay, so first of all we have to know what are, so in these graphs, what are the graphs. Okay, what is the parameters of the graph. Okay, that means literally the x-axis and the y-axis of the graph. Okay, second important point we have to know is that what are the waves that we get in a ECG. Okay, that is the P, what is a Q wave, what is a R wave, what is a S wave, what is a T wave. Okay, then third we also have to know how to calculate the cardiac axis. Okay, for that we have to know about the hexaaxial system of calculation. Okay, we are going to learn about all those things one by one. So if you enlarge this paper, okay, if you enlarge this paper, you will be able to see some thick lines and thin lines over there. It will be somewhat like this. Okay, somewhat like this. Okay, so if the speed of the machine is 25 millimeter per second, that means in 1 second it is moving at the rate of 25 millimeter. Okay, so 25 millimeter distance is covered, the machine releases the roll of ECG paper from the machine at the rate of this. Okay, so when this is happening, the calculation, what is the calculation? So each small, these are the thick lines. Okay, these are the thick lines. Okay, in the ECG strip, and these are the thin lines. Okay, so when you look closely, you see that there are, after every, in between every two thick lines, you will get 1 2 3 4, there are 4 thin lines, and that are dividing the space between the thick lines into 1 2 3 4 5. So there are 5 small squares. Okay, 5 small square between two thick lines, Okay, so, and if you do a calculation with the help of a normal ruler, you will get that distance between one small square, or the length of the one small square, or the distance between two thin lines is 1 millimeter. Okay, so we will get this 1 millimeter. So the distance between two thick lines will be obviously 5 millimeter. This means there are 5 small squares are there in between two thick lines. Now I told you the speed is 25 millimeter per second, right? So if to travel 25 millimeter it takes around 1 second. So therefore it will tell me what will be the time taken by the ECG strip to travel 1 small square. That is nothing but this distance. Okay, that means the time taken to travel 1 small square is 1 by 25. Okay, so what will be the value? 0.04 second. Okay, so this much space is takes around 0.04 seconds. So this gives us the x-axis of the graph. Okay, now let's calculate the y-axis of the graph. Okay, now for the y-axis gives you the value that is along the vertical distance. Okay, so for that you note down this value. Okay, this is showing you that 10 millimeter is equal to 1 millivolt, and that's the case. Okay, so usually what happens, to travel one small square from this distance to this distance, okay, the volt that is detected is in one small square, the volt that is detected is 0.1 millivolt. Now one small square is nothing but 1 millimeter. If it travels, it detects this much volt. Okay, therefore what will happen if I am detecting the volts from one thick line to one thick line, it will be 5 millimeter. So that will be 0.1 into 5, that is 0.5 millivolt. That is 0.5 millivolt. Similarly, what will happen if I have to travel two such distances or two such big boxes, that is a 10 millimeter, you will get 1 millivolt. Okay, so that is the machine detecting. Okay, machine is taking this much to this much volt. If you're getting a curve having this much height, it will note down that height to be 1 millivolt. Okay, so that's the y-axis for you. So we now know the x-axis and the y-axis. Now there are certain nomenclatures we should know, is that whenever we are reading any graph or ECG strip, you see some graphs are going up, okay, and some curves are going down. Okay, some are up, some are down. Okay, some are up. Okay, so this has been taken a dictum, is that a curve which is going upwards from the baseline is called as your positive deflection. Okay, and if any curve which is seen to be going downwards, okay, is taken as the negative deflection curve. And if any segment of the ECG rhythm you see to be a flattened air line or having a flat area, it is called as isoelectric line or segment. Also, if certain signals are going towards an electrode, okay, whether it's a positive electrode or a negative electrode, it shows a positive deflection. If any signal is going away or any curve is going away from the electrode, it shows as a curve as a negative electrode. So these are the normal universal dictum. Along with that, whenever a ECG recording is done, you will see that you have some reference numbers or parameters written on the strip. Okay, take for example, there this is written as 1, so this is showing you the lead 1 rhythm. Okay, here it is showing 2, it is showing you the 2 lead rhythm. Okay, let me erase the previous explanation. Okay, this is the lead 2, this is lead 1, this is lead 2, this is the lead 3 rhythm, and from here you can say there is written AVR. So it is showing you the augmented lead rhythm. This is showing you the augmented left arm rhythm. This is showing you the augmented foot rhythms. Okay, and On the right side you can see there is written V1, V2, V3, V4, V5 and V6. So all these are showing you whatever recording you are getting on a chest electrode. Okay, now in certain ECG rhythm you can see there are the curves are inverted. Okay, the curves are sometimes in a lead which are showing you a positive deflection. Okay, in certain curves you can see there is a negative deflection of the curves. Okay, here you can see there are negative deflection. Why there is a different morphology of the curve is because of the placement of the heart in the or in the conduction pathway. Okay, we know the heart is placed in a left-sided area having the conduction pacemaker point as your sinoatrial node. Okay, now supposedly this is the person's body. Okay, the heart is placed somewhere around here. Okay, the sinoatrial node will be somewhere around here. Okay, from here the current will be flowing in this direction. Okay, so first of all it will be supplying the all the atrial muscles. Okay, then we flow into the atrioventricular node. Okay, from here it will then supply all the signals to the septum, then it will be supplying the signals or depolarizing the whole of the ventricles. Okay, gradually, along with the help of the bundle of His. Okay, bundle of His. Okay, then we have bundle branch block. So we bundle left bundle and the right bundle His. Okay, so like this the depolarization waves through and throughout the heart. So you can think the heart to be current is flowing from your positive to negative terminal. Okay, so like this it is moving like this. Okay, so gradually if any electrode, okay, if any electrode is attached on this side, okay, take for example the foot end. Okay, so what will happen, so here you will get a curve which is more or less a positive deflection. If supposedly you are because it is going along the line of the electrode, if supposedly you are attaching an electrode over here which is in the reverse direction of the pathway of the usual pathway of the conduction pathway, so you will usually get the curves to be having more negative waves will be there. Now let's learn about the individual curves in the ECG recording. Let's take example this lead. Okay, lead 2. In the lead 2 rhythm strip, so you can see prominent peaks are there. Okay, these are nothing but the R waves. Okay, so in any ECG strip, because of the electrical conduction during the different phases of the cardiac cycle, that is, there is a ventricular, sorry, first of all there is an atrial systole, then we have an atrial diastole, then we get the ventricles to be systoled, then the ventricle diastoles. Okay, so this is the normal flow of the current, and that leads to the cardiac cycle. Okay, now what happens, this R waves, this peak waves that you can see is called as the R waves. These are called all the R waves of the PQRS complex. Okay, so usually we get a P wave, okay, with a positive reflection, then we have a negative curve which is called as Q wave, then we have a positive wave which is called as R wave, then we have another negative wave which is called as S wave, then we have a straight isoelectric line, then we have a positive deflection, and then we have another isoelectric line, then we again get, this is positive, is called as T wave. So then again another cycle starts. Okay, so from this point to this point is called as one cardiac cycle, from which the atrial systole to atrial diastole, the ventricle systole to ventricle diastole is completed. Okay, so we will learn about all individual curves. Okay, so in this curve you can see this is showing you the P wave. There is a very slight curve, but it's negative Q wave, which is in certain curves, it's also here supposedly it's not visible, but here again it's visible, so it varies. Okay, you have to analyze along with the other curves also. So this is a P wave, then it's a negative Q wave, then we have a positive R wave, and here there is no S wave. There should be an S wave in other curves also. So, and last is the T wave. Okay, now these are the curves. Let's learn about the individual curves first of all. So this is an enlarged form of a regular ECG waves. So the first upward curve that we see is called as the P wave. Okay, let's learn about the P wave. So P wave is an upward rounded deflection curve. Okay, the cause of this P wave is depolarization of atrial muscles. Okay, now usually the duration of a person having a normal cardiac functioning, you will get the x-axis or the duration, this particular for the time to take that it takes from to travel from one point or to other point of the curve is less than 0.1 seconds. Okay, and that is, it could be like 0.08 or 0.06. Okay, I told you the time to travel one square small square is 0.04 seconds, so it could be like two small squares or 2.5 small squares is traveling. Okay, then amplitude, that is y-axis. Okay, the amplitude, the y-axis is usually 0.1 to 1.2 seconds, 0.1 to 1.2, 0.04, sorry, 0.12 millivolt. Okay, now the clinical significance of this P wave is that it's a guide to your functioning of atrial musculature. Okay, so you will be able to know whether their atrial muscles are working fine or not. Usually these P waves are seen to be enlarged. Okay, so sometimes you will get a tall P wave. Okay, not like this, but you will get comparatively a taller P waves. Okay, so you will get more than one small square or two small square it is traveling. Okay, so you get those things or those morphology in mitral stenosis. Okay, in mitral stenosis, okay, we get a large and prolonged P wave. Okay, then we also get abnormal P wave in tricuspid stenosis. Okay, so here we will get a tall P waves. Okay, then we sometimes get the P waves having fine irregular like contractions, oscillations. Those are called those are found in atrial fibrillation. Okay, so in those waves you will not get a P wave, but a P wave are seen very small morphology, or sometimes the P waves are replaced by some fine fibrillations. The P waves are absent or sometimes are replaced by fine irregular oscillations. Okay, so in those cases you will get the curves not like a typical PQRS, you will get the curves to be going like that. Okay, and in certain abnormal conditions like having a ectopic peaks. Okay, so when cardiac impulses arises apart from the normal cardiac pacemaker cells, you will get ectopic pacemaker P waves. So P wave that you will get will be altered or sometimes even inverted. Okay, now next curve for our discussion is QRS waves. Okay, so the wave that the normal complex that we get after the P wave is called as a QRS wave. So it's a wave with a combination of three waves. Okay, there is a complex which is formed by three waves. Okay, we get a usually we get a small, the first wave that we encounter in this complex is a small negative Q wave. Okay, which is denoted as small q. Okay, which is followed by a positive R wave which is denoted by capital alphabet, and that is followed by another negative wave which is denoted by a small s or s wave. Okay, the cause of this QRS complex R, or the physiological significance of this is it depicts the ventricular depolarization. Not only this, it also depicts you the atrial repolarization. So the P wave was showing you the atrial systolic phases or the atrial diastolic depolarization phase. QRS complex is showing you the ventricular depolarization. Along with that, the P waves or the atrial repolarization phase is also hidden in this, inside this complex. Okay, now let's learn about the parameters. The duration, whenever we speak about duration, it's the x-axis. Okay, so in the x-axis it usually takes 0.08 seconds. That means it's taking a space of two small squares approximately. Okay, if you are getting to be more than two small squares, it just takes one small square, then two small squares. Okay, so supposedly it's taking more than this, then you can see that it's a prolonged QRS complex. Okay, then the amplitude. Now the amplitude is showing you the parameters that is in the y-axis. Now in this case, since this is a complex wave, so we have three curves. Okay, let's learn about individual curves when it is normal. So whenever you are getting the Q waves, you should get the Q waves to be having the volts of around in the range of 0.1 to 0.2 millivolt. The R wave, the volt should be in the range of, or it should be in the range of 1 millivolt, 0.08 to 1 millivolt. The S wave, its volts or potential should be 0.4 millivolts. If you sum all this total, okay, then you should get the values from 1.5 to 1.6 millivolt. Now here the concept you have to know about all this total positive this volts. Okay, so this is very important in calculating the cardiac axis, which we will be discussing in the later half of the video. Now point Q waves, let's learn about this point Q wave. Okay, so that means showing you, I told you to travel one small square it takes around 0.1 millivolt. Okay, 0.1 millivolt. Okay, so that means the Q wave should be at least covering one small square vertically. Similarly, the S wave. Okay, I told you the SQ wave is negative wave, so you are getting the waves in an inverted fashion. Okay, now S wave is again a negative wave. It travels at least 0.04 millivolt. Okay, so that means it is traveling 0.4 millivolt. I told you one small square is 0.1 millivolt, so therefore it should be covering at least 4 small square. So 1, 2, 3, 4. So you can see the negative wave is traveling at least 4 small square vertically down. Now the next positive wave is the R wave. Now from where to where? Now whenever you are judging whether it's a positive wave or a negative wave, you should always remember to count it from the isoelectric line, the straight lines which is connecting all the individual curves or the curves in the or the waves in the ECG strip is called as the isoelectric line. So these are called as the isoelectric line, in which the positive, all the positive deflection and the negative deflection are negating each other and forming an isoelectric line. Okay, so from this point onwards, if you are getting a positive wave, you should move upward. If you are getting a negative wave, you should move downward. Okay, so Q wave is a negative wave, so it was going down from the isoelectric line. S wave was a negative wave, so it was going down from the isoelectric line. Okay, like this. Okay, now the R wave is showing you a millivolt of a normal case, 1 millivolt. So that means you have to travel at least, if 1.1 is the volt for one small square, so that means we have to travel 10 small squares. That means from here 1 2 3 4 5 6 7 8 9 10. Okay, at least 10. So one small square is 2 3 4 5 6 7 8 9 10. So since it is not actually actual depiction, so you can think it more or less it is traveling at least 2 small squares more. Okay, so approximately the curve should be like this. Okay, so it's not an actual authentic diagram, so you can judge what is a pop PV wave. My main aim to give this picture is to make you explain what is the millivolt. Okay, so whenever you are doing a calculation of cardiac axis, in this case you have to sum all the curves. Supposedly in this curve, supposedly it is 1 millivolt. Okay, so it's 1 millivolt. R wave is positive 1 millivolt. Okay, S wave. Now out of the negative waves, which one is the more negative? The S wave. Okay, so we have to take the negative wave first. Okay, so the more negative wave, so S wave is the 0.04 millivolt, so we have to take that one as 0.04 minus. Okay, now how to give the QRS naming convention. Okay, so how to name those QRS complexes if there are. So I have told you, told you there are different morphology based upon whatever leads you are taking. Supposedly some QRS complex are looking like this. Okay, some QRS in some leads you will look and you will see those this QRS complex looks like this. Sometimes you will also find the complex looking like this, then like this, then certain curves you will get having this kind of a morphology just. Okay, then this kind of morphology, then this kind of morphology, and in certain curves you will get this kind of morphology. Now all these are showing you the QRS complex only. Okay, supposedly whatever curve you are getting which is a negative curve, the first curve in the QRS complex you are getting a negative wave, that has to be always the Q wave. Okay, and if supposedly you are getting a negative wave along with a positive wave, then you nomenclate the complex as QR. Okay, supposedly this curve having a very big R wave, then also you are going to name it QR. Okay, now supposedly you are getting, okay, whenever you are getting a negative wave, you always have to use this nomenclature, small q. Okay, small q and capital R. And this wave, okay, I told you the first wave that we encountered, that's a negative wave, that always have to be the Q wave. Okay, then we have a positive wave. Okay, that's a capital R. Then we have another negative wave, that is, if you are getting another negative wave, that's called as the S wave, which is denoted by small s wave, S letter. Okay, the first curve, then whenever you are encountering that is a positive wave, as for example this way, you always have to give nomenclature of R wave. Okay, the first positive wave is always an R wave. If supposedly you are getting in this complex a positive wave, then a negative wave. Okay, so then you will give this nomenclature is R wave, and immediately after a positive wave you are getting a negative wave, that is always have to be a S wave, and that's a negative wave. If you're getting a smaller positive wave, then also it's a R wave. Okay, then we have a negative wave, that is a S wave. If supposedly you are getting a wave having two positive waves, okay, I told you the first wave that we encounter, if it's a positive wave, is an R wave. Okay, then immediately after that, if you are getting a negative wave, that's an S wave. Again, if you are getting another curve which is positive, then it is might be because of some ectopic bits. Okay, so then you have to nomenclate that, give the naming as R prime. Okay, then you should name it as R prime QRS complex. Okay, now some clinical significance is that sometimes you will get deep QRS waves. Okay, now these waves are found in having parameters of more than 0.2 millivolt of its amplitude. Okay, and you will get those waves usually in a myocardial infarction. Okay, myocardial infarction. Okay, then you might also get some waves QRS complex having a tall R wave. Okay, these tall R waves are found to having the y-axis or the amplitude to be more than 1.3 millivolt. These are usually seen in conditions like ventricular hypertrophy. Then in certain conditions you will get the QRS complexes to be having low amplitude. Okay, low amplitude, that is, you will get the complex to be having the duration as less than 1.5 millivolt. Okay, you will get those complexes in hypothyroidism and pericardial effusion. Sometimes you will also get the QRS complex to be having prolonged. Okay, so what are the cases? You will get those things in conditions having bundle branch block. Okay, it could be the left or the right, whatever. Okay, next wave for a discussion is the T wave. Okay, T wave. Now T wave is the last positive wave that is seen in the ECG rhythm. Okay, the cause of this is ventricular repolarization. Okay, that means the relaxation of the ventricles. The duration of this T wave is seen to be 0.25 seconds, and amplitude of this wave in a normal condition is seen to be around 0.3 millivolt. Okay, 0.27, that means it is traveling at least of, I told you, if it is traveling one small square is taking 0.04 seconds, so it has to travel at least of 5 small squares. Okay, so 1 2 3 4 5 and 0.3 millivolts. So that means it is showing you, I told you, in one small square it travels around 0.1 millivolts, so it is traveling at least 3 small squares in the vertical direction, 2 3. Okay, at least of 3 millivolt. Okay, now what is the clinical significance of this wave? Okay, clinical significance significance. First clinical significance is that it is showing you the ventricular repolarization. Okay, now some abnormal conditions where you will get the abnormal T waves is that sometimes you will get a flattened T wave. Okay, flattened T wave. When do you get those things? Usually it is also found physiologically in old age persons. Then in certain conditions you will get T waves to be the amplitude will be increasing. Okay, or sometimes you will get the T waves to be inverted T waves. Okay, sometimes you will also get like tall or peaked T wave. Okay, now increased amplitude is also seen in certain healthy persons. Physiologically it is also present on those persons. Okay, sometimes it is also present in hyperkalemic conditions. Hyperkalemic, that means if potassium ion concentration is more in the blood, then also you will get more higher T waves. Okay, inverted T waves is usually found in myocardial infarctions. Okay, tall T waves, so potassium is peaked. Okay, so amplitude again increases in this case. So in digitalis toxicity also you will get the inverted T waves, digitalis. Okay, so there's a drug whose abuse might lead to inverted T waves also. Now apart from the normal PQRS complex and T wave, we also get in certain conditions some trivial waves like the U wave. Now this wave is called as the U wave. That's a small positive wave. Now the cause of this wave is slow repolarization of papillary muscles. Okay, so there is a muscle called as papillary muscle which is attaching the cuffs. Okay, so in every heart, so whenever you are entering a chamber, you will get a valve. Okay, now these valves are not a simple musculature. It is attached with the help of some tendons to the other chamber. Okay, so it is attached to the atrial chamber or the ventricular chamber by the help of some musculotendinous fibers. Okay, those are called as the papillary muscles. Now these are helping it to remain in a more or less in a flexible state. Okay, so flexibly firm manner it is remaining in a position in a normal anatomic position is being kept with the help of the papillary muscle. Now what happens is that certain conditions those muscles become those musculotendinous fibers becomes more stiff and it causes some recordings to be recorded. Okay, so supposedly the duration of this papillary muscle this U wave is usually seen to be around 0.08 seconds and the amplitude it's 0.2 millivolt. Okay, clinical significance of this is that it's rarely seen in healthy individuals but becomes significant in hypokalemic individual. Okay, that means a person having potassium in the blood in a lower than the normal required level. Now apart from some waves or curves that we get in an ECG rhythm, there is a PQRS complex and T waves and U waves. You also get some segments and intervals. Okay, segments are if you're connecting two dots, okay, by a straight line, that is called a segment. Okay, and if two points are connected by not a straight line but there are some waves in between, those are called as intervals. Okay, so segment are those part of the ECG rhythm in which it is connected by straight lines, and interval are those parameters in which you are connecting to 2 points, and in the 2 point connection there might be some positive wave, there might be some negative waves. Okay, these are the normal funda of to interpret what is what. Okay, now first such intervals that we encounter is sometimes called as PQ or sometimes called as PR interval. Okay, now I told you if it's an interval, the points have to be joined by a curve and a line. Okay, so let's think it to be the P and R wave. Now what's the difference between these two is that if you're connecting supposedly the point from starting of the P wave to the start of the QRX complex, that is same only if you are signifying it to be the PR or the PQ. Okay, the starting point is a Q only. Okay, so this particular segment is called as the PR or PQ. Okay, that is time interval from beginning of P wave to the start of QRS wave. Okay, so it is the interval which is showing you the beginning of excitation of the atria, that is excitation of atria plus the beginning of excitation of ventricle. Okay, so excitation of both of the atria and the ventricles are being showed in this interval. Okay, the normal duration of this interval is 0.167 seconds. Okay, that means it is traveling at least of 4 small squares or 5 small square. Okay, so 1 2 3 4 5. Okay, so 5 or 4. Okay, it doesn't matter. So clinical significance of this interval is that it indicates how fast the action potential is transmitted through AV node from atria to ventricles. So supposedly this PQ interval is prolonging, so supposedly there is prolongation, then you will be able to suspect that there might be some blockage in the AV transmission or the AV node. Now next interval for our discussion is your important is QT interval. Now QT interval, so it's an interval, so that means it is this part of the it is joining, the 2 points are being joined by a straight line or isoelectric line and some positive or negative waves. Okay, so it is actually showing you this interval from beginning of Q wave to end of T wave. Now which is the beginning of Q wave, this is the beginning of the Q wave, and the end of T wave is this. If you're connecting these 2 points and you're measuring, this is nothing but the QT interval for you. So normal duration of this interval is 0.35 seconds. The clinical significance of this interval is it is showing you duration of ventricular systole. Okay, supposedly there is a prolongation of this interval that is actually showing you nothing but ventricular, it is usually found in ventricular arrhythmias. Okay, next segment or interval is a very important, which is called as ST segment. Now I told you, if we are connecting 2 points by a straight line, that is called as a segment for you, whereas interval are the 2 points whenever it is connected by a straight line and a curve. So since this is a segment, it has to be a straight line, so it is an isoelectric line or period between the end of QRS complex and beginning of T wave. Okay, supposedly this is the curve that you are getting, so is between the end of the QRS. So after the end of the S wave, this is the end of the QRS complex. So supposedly this is the first point and the beginning of the T wave, and this is the point at which the T wave is starting. So this is the isoelectric line, which is called as the I segment. Okay, so usually the duration that we get in a normal cardiac rhythm is that 0.32 seconds. Okay, clinical significance is that it corresponds to ventricular repolarization. That means it is the time which it takes the ventricles to relax. Okay, corresponds with the ventricular repolarization. Another important point while calculating the ECG cardiac axis is that we have to know about the J point. Now the junction between the isoelectric line, that is the ST segment, and the negative S wave is called as the J point. This is called as the J point. Remember this, we are going to need this in the later calculation class. Now let's talk about your heart rate calculation. Now usually in spotting, ECG rhythm strip is given and you have to determine the heart rate. So whenever I will advise to use the second lead usually to check the heart rate. Now there are two formulas for checking the heart rate from a regular ECG recordings. Is that one is if you're using the larger boxes. So usually the heart rate is calculated in beats per minute. Okay, so usually if you are using the larger boxes, as for our calculation we have to use the formula as 300 divided by number of large boxes. That is, this is one box. Okay, this is one box, this is another box, this is another box, this is one large. How many such large boxes come between two RR intervals? Okay, between two RR waves. Okay, another formula is that we can calculate the heart rate by using the small square. So for that we have to use this formula, 1500 divided by number of small boxes between 2 or 2 RR intervals. Let's use this formula in our heart rate calculation in this ECG strip. Okay, so let's take the second lead readings and this is an R wave, this is an R wave. Let's take these two R waves and let's see how many large boxes came. So this is one box, this is two box, this is three box. So there is kind of a 3.5 boxes are there. So 3.5 large boxes are there. So if you are using the large box calculation, I told you heart rate is equals to 300 divided by 3.5. so the value approximately after calculation comes out to be 85.7 beats per minute. Okay, let's see match with our value in given by the heart machine. So it is showing you the value 82 beats per minute, more or less the same value only. Now let's use the small box in our calculation. Okay, so these are the two R waves. Okay, how many small waves are there? So since we know in between two thick lines there are 5 small squares. Okay, so if I'm getting 1 2 3 small boxes, so that means we are getting 5 to the 15. So we are getting 15 small squares plus 1 2 3, 15 plus 3, we are getting 18 small boxes are there. So let's apply the formula in the small box calculation. For that, 1500 divided by 18, so we get the value to be around 83.3 bits per minute. So it is also very much close to this value. How the bipolar limb leads are connected. Now told you there is a left arm lead, there is a right arm lead, and there is a left foot lead. Okay, now we know that these are the standard leads that we usually use for our instrument. Okay, we attach this to the right arm, this to the left arm, this to the left foot, and this as a negative terminal, neutral terminal in the right foot. Okay, so when we are attaching like this is the right arm. So red one is connected like this, the yellow one is connected here. Okay, and the green one is connected over here. Okay, so this is the way we connect it. Now internally, whenever you are dissecting this leads, is supposedly you are dissecting this. Now what happens is that you will get it is a clip, like it has a clip motion. Okay, so it has a spring action over here. You just squeeze around these two areas in the clip area, and these prongs will open up, and then you just just like the clip, we just attach or fix it on the wrist. Okay, now these leads have a positive terminal and a negative terminal. Okay, all these have a positive terminal and a negative terminal. That's why the name bipolar lead is stuck. Okay, so this leads positive and negative terminal can be decided based upon what lead you are using. Okay, now these as such, these are called as your electrodes. These clips are called as the electrodes. Okay, now combining any two electrodes together, it forms a lead. Okay, so lead is an imaginary parameter of a ECG machine. Okay, and electrode are a physical part of the ECG machine. Okay, that we actually clip it with the body. Okay, so if supposedly the right arm, in certain situation, if you are going to use these two clips as our sensor, okay, connecting these two clips together, the machine uses the galvanic instrument to detect the volt between this and this end. There is the right arm and left arm, whatever volt it is detecting as the volt of the volt as lead 1 volt. Okay, so this is called as a lead 1 volt. Okay, now in this case, this particular connection, the red and the yellow, sorry, so this is a red one. Okay, so it is connected to the right arm. So when you are using these two clips together, it is giving you the volt of the lead 1 volt. Okay, now in this case the right arm acts as the negative terminal, the left arm acts as a positive terminal. So the current is flowing around the along the direction from the negative to the positive pole. Okay, now if supposedly under another situation you are using the left foot, okay, and the clip of this left arm, in this situation the volt that is detected between these two clips or these electrodes is called as the lead 3 volt. Okay, okay, whatever volt you are getting is because of the potential between these two arms, okay, these two limbs. So when this lead 3 volt is active, okay, these 3 volts are active, then the left arm acts as the negative terminal and the left foot acts as the positive terminal. Similarly, if we are using this and this, that is the right arm electrode and the left foot electrode simultaneously with the galvanometer, okay, when keeping this left arm terminal potential to be absolutely zero by passing it through the Wilson's terminal, what happens, the volt that is detected is called as the lead 2 volt. Okay, in this case what happens is that the right arm acts as our negative terminal, the left foot acts as our positive terminal. Now have you seen one thing, the right arm terminal is always used as the negative terminal and the left foot is always used as the positive terminal, and this is actually the line of passage of the electrical conduction pathway. So the sinoatrial node is over here, the AV node is there over here, and the signal is passing like this. Okay, as you know from your theoretical knowledge, it is passing like this, and this is along the direction of the pathway or conduction pathway of the lead. So any lead which is along the pathway, supposedly you are detecting the lead 3 volt. Okay, if you look in closely into the lead 3 rhythm strips, you will usually get the normal morphology of the leads, that is PQRS complex. Now if you go back and you look into the ECG strip and show the right arm strip, okay, more or less you will get the negative waves over there. Sorry, not the right arm but the lead 1, or in this case augmented AVR, you will get those PQRS complex in an inverted fashion. Okay, take for example this curve only, AVR, look into the AVR curve, you see the R complex and compare that to the lead 3, okay, or lead 1 or lead 2. Okay, see all these curves are positive and here it is getting a negative wave. So that's the significance of knowing which leads are placed where and how the lead is formed and how what is the difference between lead and electrode. Now let's learn about the hexaaxial system. Hexaaxial system. Now this is a system which uses a 6-axis quadrant. Okay, 6-axis quadrant or graphical representation. Now usually we know there are an x-axis, a line going through in the graph paper, that is aligning with the horizontal line, is called as the x-axis, and the line which is perpendicular to the x-axis is called as the y-axis. Okay, this is the normal two-dimensional graphical representation. Okay, now we at this particular time know about these two leads, these two axes. Now we know lead 1, lead 3 and lead 2 is placed in the body in certain points in the body which is making certain angulations with that of the heart. Okay, placing the heart at the very center, the lead 1, this lead 1 is actually aligning with the horizontal axis. Okay, so lead 1, if I'm supposedly drawing the lead 1 in the hexaaxial system, so lead 1 is going at a 0-degree angle. Okay, in a hexaaxial system we just plot each and every leads with respect to the graphical representation of the axes. Lead 2, let's place the lead 2. Now lead 2 is starting from the right arm and going to the left arm is making it an angulation of 60 degrees. So the leads, I forgot to mention about this, the depiction that is shown over here is showing you the Einthoven triangle. Okay, now Einthoven's triangle consists of three, is a triangle formed by three surfaces or three arms, which is making an equilateral triangle because each and every leads are making an angle of 60 degree. Now since lead 2 is passing at an angle of 60 degree with the lead 1, then what you'll do, you are going to put this or extrapolate this lead 2 at a 60 degree angle with that of the lead 1. Okay, so that comes your lead 2 in an hexaaxial system. Now lead 3 is again making an angulation of 60 degree, or you can say to be the 120 degree with that of the lead 1. So if this is the lead 1, so 120 degree from lead 1 will be what? This is the 120 degree. So this is the lead 3 for you. Okay, which is making an angle of 120 degree. Now remember, since we are not using a mathematical graphical representation, it's a depiction of the electrical potentials of the heart. So in this case, I told you the sinoatrial node generates all the electrical impulses, and it generates the impulses from the negative to the positive terminals or the hyperpolarized tissues. Okay, so whenever a tissue is polarized, it's the outer surface becomes a negative, and the tissue which is non-polarized, the outer surface is positive. So current always travels from negative to positive terminal. So taking this concept in reference, we always will get to see all the graphical representation of negative markings or negative values above to the 0 degree, and all the positive values will be given below the 0 degree or horizontal axis. Now I told you there is an augmented, okay, so we have three augmented leads. There is augmented left arm lead, there is augmented right arm lead, there is an augmented foot lead. Okay, now I told you the augmented are nothing but 3/2 times of the voltage that is detected in the limbs. Okay, so there is nothing but 3/2 times of voltage recorded in the foot, and this is nothing but 3/2 times recorded with the voltage of arm. So that means what? It has a positive value with that of the potential that is detected in the left arm. So whenever this is happening, this is augmented values is approximated to a value of about 60 degree from the horizontal axis. So AVL, if supposedly this is the lead 1, okay, with that AVL, okay, and this augmented left arm is 3/2 times of the left arm augmentation. So you always have to think it that it has a value little bit higher or 30 degree higher than the lead 1 potential. Okay, so you extrapolate the value of the augmented, sorry, not 30 degree but at least 60 degree. Okay, 60 degree to that of lead L. Okay, that is the left arm. Similarly, the right arm augmented value, that is 3/2 times, is taken as 60 degree to that of the negative lead, since it's on the left side of the heart, so that is taken as the AVR. And foot, it is passing perpendicular to the axis of the heart. Okay, so the third augmented, that is AVF, is taken as 90 degree to that of the one axis. Now whatever figure you are looking right now here, the graphical representation of all the axes and the leads is called as a hexaaxial system. Now keeping this picture in mind, we are going to calculate the cardiac axis. Now this is one triangle for you, with having the three limbs depicted by the leads 1, 2 and 3. Now there is a concept called as Einthoven law. Now this law, it depicts the summation of two leads, it has been seen to be equated to the potential of the other third lead. That means this Antho one, he found that the potential whatever it is detected by the leads, if we are summating the lead 1 potential with that of the lead 3 potential, it approximately equals to the potential that is detected in the lead 2. So that means if we are adding these two values, and we should be able to get the value that is detected in the lead 3, that is called as the Einthoven's law. So if the electrical potential of two leads are known, in some cases we can be able to find the unknown potential in the third lead also, okay, by summating the other lead. Or supposedly lead 2 and lead 3 is given there, so lead 1 can be calculated by subtracting the lead 2 from the lead 3 potential. So that's called as the Einthoven's law for you. Okay, another concept relating to the ECG is anatomical groupings of the leads. Okay, now why do we need to know the lead 1, lead 2, lead 3? Then we have augmented R, augmented L, augmented F, then we have the V1 to V6 leads. Okay, all these rhythm strips, we as a physician, we should know all the rhythm strips, how does it look like, and if supposedly there is some abnormality that is detected in one or two leads or few other leads, then how to interpret the result with respect to the anatomical position of the pathology. Okay, for that we should know the nomenclature of the leads with respect to that of the part of the heart. Okay, so usually whenever we are looking into an ECG strip, we are actually looking into the abnormalities in what part of the curves or waves or what leads. Okay, take for example V1 to V2. Okay, if there is an abnormality, it will detect in the V1 and V2 strips. That means it is showing you abnormality in the anteroseptal part of the wall. That means, so if there is this chamber, there is a right atria, left atria, then is a right ventricle, left ventricle. So there will be an area which is joining the two chambers of the atria and two chambers of the ventricles. These are called as septa. So anterior septal, so front part of the septal wall, if there is any problem, so you will detect in V1 and V2 leads. Okay, if supposedly there is abnormality in the V3 to V4 leads, okay, then you will be able to see the abnormality in the anteroapical wall. That means apex is this part of the heart, that is at the tip. Okay, so it is showing you the abnormality is detected in the tip part of the heart. If supposedly you are getting an abnormality in lead 1, okay, sometimes lead 5 and lead 6 of the chest leads, as well as the left part of the leads, okay, left arm lead. So that is actually showing you the lead 1, that is connecting the right arm with the left arm, as well as the augmented AVL, that is on the left part of the body, as well as on the leads which is attached on the axillary end or the mid and the anterior axillary fold. That means it is showing you all the values that is around the left part of the heart. Okay, so it is showing you abnormality in the anterolateral wall of the heart. Okay, if supposedly there is abnormality in the lead 2, lead 3 and AVF, irrespective of whatever condition you would get, you will usually get those problems that is on the back side of the heart, that is the inferior wall of the heart. And supposedly AVR, that is the extreme right corner of the heart, that is abnormality in this lead will show you the abnormalities on the posterior wall of the heart. Okay, So individually, supposedly you are getting an abnormality in ECG strip having abnormality in V1 and V2. So these two leads. So you will get abnormal PQRS complex or abnormal intervals or abnormal segments. Then you should suspect there is anteroseptal wall defect. If supposedly you are getting any abnormality in the V3 and the V4, then you should suspect it to be the apical wall abnormality. This is a septal wall abnormality. Okay, this is apical wall abnormality. So if there is an abnormality in the lead 1, okay, and 5 and 6 chest leads, as well as the left lead, that is the anterior lateral wall abnormality, okay, you will suspect. Or if you are getting an abnormality in lead 2 and lead 3, along with that the foot lead, then you suspect that person will have the inferior wall abnormality. Or supposedly you are having a ECG rhythm strip having abnormality in the VR only, then you will suspect that person to have the posterior wall abnormalities. Now by this time you also know about the hexagonal system, which is a combination of all the leads in the axes of the graph. So supposedly you have to do the cardiac axis calculation. First and foremost, you have to draw the curves, though the axes or the leads of which potentials you are going to check. Supposedly I'm checking the lead 1. Okay, I'm selecting the lead 1 and the lead 3 in this case. Okay, lead 1 and lead 3. Or supposedly I am checking the lead 1 and lead 2. Okay, these two are more prominent over here. I'm checking this thing. Okay, so I will erase all the other leads accordingly. Okay, so in the hexagonal system I don't need the lead 1, the AVR, AVL, and the AVF is also not needed by me. Okay, so now just the lead 1 and lead 2 is needed by me. Now for this I've told you how to calculate the potentials of the mean potential of the QRS complex. So you have to check the QRS, since R wave is the biggest positive wave in the PQRS complex. So you have to check the QRS complex first of all. Now I've told you the first negative wave is the Q wave in the QRS complex. The first positive wave is the R wave. So for that you take two QRS complex. So let's take this QRS complex and let's take this QRS complex. Okay, now if you enlarge this, you will see that in this wave this is the isoelectric line, then we have the P wave, then we have another isoelectric line, then we have the S wave. Okay, now this is the isoelectric line from which we have to reach up. Okay, now since there is no negative wave, so there is just this positive wave, we just have to keep our concentration on the number of small waves. Now there is 1, 2, 3, 4, 5 and 6. So there is a positive deflection of 6 millivolt, positive 6 millivolt. Okay, now this will be our mean QRS complex of the first lead. The lead 2, let's keep our concentration on the lead 2. So this is the isoelectric line and this is the R wave. Okay, so how many small squares are there? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So there is positive of 10 millimeter gap between the isoelectric line and the peak of the R wave. Now for your clarity, let's take for example this wave. In the lead 3, let's take this wave. Now in this wave, see, this is the isoelectric line. Now from the isoelectric line you can see there is a negative deflection curve and there is a positive deflection curve. Now you have to take the mean of the negative and the positive deflection. So how many small squares are going for the positive deflection curve? 1, 2, 3. And how many waves are going for the negative deflection curve? There is 1, approximately 1. Okay, so 3. So there is plus 3 volt for, sorry, plus 3 reflection. So there is plus 3 deflection for your R wave, and there is minus 1 deflection for your S wave. So the mean volt or is traveling is point plus 2 millivolt. Okay, like this we calculate the mean axis of the QRS complex. Now you have to plot these values in the curves to get the QRS complex, mean QRS complex. Let's take lead 1. Now since we have calculated the in the lead 1 the plus 6 millivolt, okay, supposedly you are plotting it on a graph paper, the hexagonal system, so obviously there should be some markings which is depicting you the x-axis, okay, and there will be some markings which is depicting you the y-axis also. Okay, so individually all the axes we will get some markings. Now supposedly I'm getting the mean QRS complex in the lead 1 as plus 6. So this is the plus 6 that we are getting. So you have to plot the plus 6 in the first axis, first lead axis. There is a 1, 2, 3, 4, 5, 6. So from this is the plus 6 millivolt. From here you draw a perpendicular line. Okay. Now you can take either lead 2 or lead 3 in this case. Okay, so let's take the lead 3 in this case, or 2. Okay, lead 2 is giving you plus of 10. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So somewhere around here you draw the perpendicular line. The perpendicular line is crossing somewhere at one particular junction. You from the axis you draw a straight line to the meeting point. This is the mean QRS complex for that particular patient. Similarly you can use the lead 3 also as an example. So lead 3 is showing you a complex of plus 2 millivolt. Okay, so if you are drawing supposedly from the lead 2, so it will have a perpendicular marking which is crossing over here. Then also you are going to get, if you are taking lead 1 and lead 3, then also you are getting the same QRS complex. So this is the mean QRS, this is the mean QRS axis of a person, and that has a significance in ECG recording and interpretation. So the mean QRS in a normal situation axis should lie from minus 30 degree to plus 110 degree. I told you all the axes which are going below the lead 1 is taken to be the positive deflection, and anything which is going above the horizontal axis of the lead 1 is taken as the negative axis, negative degree. So the mean QRS complex should always be situated somewhere from the minus, if this is the vertical axis, so it should be somewhere from this 30 degree negative to positive 110 degree. This is supposedly 90, this is 110, this is 110. So the mean QRS complex or axis should be somewhere around here. This is called as the normal axis or normal QRS axis. Now apart from that, there we have a left axis deviation. Okay, left axis deviation. It happens when the degrees of the mean QRS is from minus 30 degree to minus 90 degree. That means extreme of the left. Okay, so extreme of the left matlab minus 30 to this area that I'm shading. It is showing you the left axis deviation. It is showing you the left axis deviation. then this left axis deviation is showing you. Then we have another called as the right axis deviation, which is from the degree of plus 111 to plus 180. That means it is starting from here and it is reaching to the this particular marking. Okay, so this is the right axis deviation for you. This is the right axis deviation for you. Okay, and anything which is left in between the left and right axis deviation is called as a extreme axis deviation or extreme or intermediate interdeterminate axis. Okay, so it situated from minus 90 degree to plus 180 degree. Okay, so there are certain conditions in which you will get a right axis deviation and left axis deviation. So this is the normal axis deviation. I told you from minus 30 to plus 110, and from 111 degree to the positive 180 degree is called the right axis deviation, and from the minus 30 to minus 90 is called as the left axis deviation. Okay, this is the left axis deviation, this is the right axis deviation, this is the normal axis, and this is the indeterminate axis, that is the extreme axis deviation. Now when does a left axis deviation occurs? The left axis deviation is usually found in conditions like left ventricular hypertrophy. Okay, you might get this left axis also in a left anterior hemiblock. You might also get this left axis deviation in Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome, or you might get in inferior myocardial infarction. Okay, the right axis deviations are usually found in conditions like right ventricular hypertrophy. You might also get those axis deviations are left posterior hemiblock or Wolff-Parkinson-White syndromes. Okay, this is a condition where you might get the left or the right axis deviations, and also in dextrocardia, that is right sided inversion of the heart. So there are some abnormal ECG readings like sinus tachycardia, in which there is normally there is more heartbeat. Okay, so the heart rate will be increasing in those persons, will be more than 150 beats per minute. Okay, so you will invariably, if you're going to check the RR intervals between two tall peaks, you will get those intervals to be decreasing. Okay, it will be decreasing then the required amount, that is approximately it should be around 20 to 30 small squares, so it will be lesser than that. Sinus bradycardia, obviously there will be decreased latency or increased latency in the transmission of the conduction. So here the heart rate will decrease from less than 30 beats per minute, so here you will get the RR interval to be prolonged than the normal. Sinoatrial block, that a point in which there will be a missing PQRS complex, so that means sinoatrial node will miss one impulse. Okay, so there won't be any depolarization or propagation of the impulses, so there will be an absent cardiac event. Then we have the first degree heart block, in which you will get fixed PR interval will be increased more than 0.02 seconds. So the PR interval will be more than that's required for the normal case. Okay, so you will have a fixed increase in the PR interval. Okay, you just check the PR interval in individual complexes, and then you judge whether it's a first degree. In second degree block, what happens, the PR interval will prolong. Okay, and that will lead to atrial P wave but no QRS complex. That means what will happen, the PRS complex will gradually keep on increasing and increasing and increasing. A time will come when the QRS complex will be absent, and then it will again resume its normal sinoatrial node. Complete AV block. In complete AV block, there will be no relationship between the rhythm of the P wave and that of the QRST complex. Atria beats at 100 beats per minute, and ventricles beat at a lower beat, that is 40. So if you see the PP waves, okay, individual PP waves are maintaining its duration. Okay, whereas if you check the PQRS complex, so you will get the PQRS complex to be variant. Okay, but when you check the QRS complex, that will be maintaining its duration. So that is showing you the complete AV block. The next is showing you the ST elevation, which occurs in ischemia. Okay, so I told you the junction between the negative S wave and the ST segment is the J point. Okay, if supposedly the J point is below the isoelectric line. Now I told you the isoelectric line is the line which is equipotential from positive and the negative. So if the isoelectric line on the ST segment is elevated in any curve or any lead, that's called as ST elevation. So you can see the ST segment. So ST segment is elevated from the isoelectric line. If supposedly the isoelectric line is a little bit higher than the ST segment, that is called as the ST depression. So you will get in ST elevation convex upwards, and in a ST depression you will get the concave upwards. Okay, so usually the ST elevation and depression might be present in the same patient also, and the lead which is opposite to the lead having the ST elevation, you will get the ST depression. The next is the atrial flutter. So it's a very fast moving beating heart in which the P waves are strong in amplitude, and normal QRST complex after every 2 or 3 atrial P waves. Okay, so you will get after every 2 P waves you will get a QRS complex. Okay, and the P waves are strong in amplitude. That means that you will get a very higher amplitude P waves. So the P waves will be bigger in morphology. Okay, atrial fibrillation, in which either no P waves or fine high frequency low voltage wavy P waves. So the main takeaway point is wavy P waves will be there, and QRST and T complexes are normal. So you will get the P waves to be wavy. Okay, whereas in atrial fibrillation there will be no repetitive ECG pattern, low variable voltage of 0.1 to 0.5 millivolt, and it will have a coarse and irregular waves. Okay, now this is a typical pattern of a ventricular fibrillation, in which you can see the atrial waves are even absent, the P waves are absent, and you will get the complexes in the form of an sawtooth. Okay, so the difference between the atrial flutter and atrial fibrillation is a little bit difficult. Let's look into. So atrial flutter, atrial fibrillation compared to atrial flutter. So difference is that in case of the fibrillation you will get the P waves are absent or replaced by isoelectric line. Okay, in case of flutter, the P wave will be replaced by flutter or sawtooth appearance. In case of an atrial fibrillation, you will get the atrial rate to be 400 to 600 beats per minute, whereas in case of an atrial flutter, the beats will be from 250 to 350 beats per minute. That means this one has a little bit lesser rate of beat, and this is have a higher rate of beat. Okay, so you will get a sawtooth appearance in this. Okay, this is a sawtooth. It looks like a sawtooth. Okay, this it doesn't looks like a sawtooth, but sometimes you will see the P waves to be changed into an isoelectric line somewhere. Okay, in some points, okay, you will say as an forming in the isoelectric line. Okay, then third point is rhythm. In case of your atrial fibrillation, you will get the rhythm to be irregular. Okay, the irregularity will be coming at irregular intervals, whereas in case of atrial flutter, it will be generally regular in rhythm. Okay, regular atrial rhythm. Now moving on to the next is the hyperkalemic ECG graph. So typically in hyperkalemic and hypermagnesium, that is potassium and magnesium individually or together, if it is increasing, you will get progressive diminution and eventually disappearance of the P waves. The P waves will disappear. Okay, the P waves will disappear, as well as you will get widening of the QRS complex and tall and widened T waves, and there will be shortening of the ST segment. So you can see there is widening. Okay, there is widening of the QRS complex. Okay, as well as the ST segment is decreasing. Okay, and shortened. Okay, and there will be tall and slender T waves. Okay, widening of the QRS complex. This will be the visible feature. In case of hypokalemia and hypomagnesemia, that is potassium level is decreasing as well as magnesium is decreasing, you will get the opposite effect. There is lengthening of the PR interval as well as there is a progressive diminution with eventually disappearance or inversion of the T waves. Okay, the T waves will be inverted. You can see the T waves are getting inverted. Okay, and sometimes in certain cases the ST segment depression you will be able to see. Okay, and there will be prominent U wave.